So it can also goes by sexual transmission from young adults, very common in adolescent, teenage and young adults group. So you get genital molluscum, very common, and this basically it caused by injury. So any injury in the skin mark, if the virus goes there, it grows there. So the disease is rare under the age of 1 year due to maternally transmitted immunity for long incubation period. Vertical transmission responsible for lesions detected in first few days or weeks of life. Peak incidence about 2 to 5 because in children it is very common. So predisposing factors, sexual abuse in children, atopic eczema. Why atopic? Because they scratch, so there is the barrier is affected, skin barrier, so the virus goes and sits there and it grows. Topical steroids, topical calcium inhibitors, they lower the immunity. Eczema, then in patients with HIV, malignancy, sarcoidosis, idiopathic CD4 lymphocytopenia, hyper IgE syndrome, these are all there. Molluscum is very common. In HIV patients, you can see molluscums are huge, big size. So then you can suspect molluscum. Okay. So this is the microbiology part. You don't have to not required much, but you can just know the types M1, MCV 1, 2, 3, 4. So 1 is very common. So this is the subtype which is very common. So basically pathology, this is very important. The virus enters the basal epidermis causing an increase in the cell division extending into the supravasal layer. The cellular proliferation produces lobulated epidermal growths which compress the papilla, and these are like histological features. I will bring the pictures, then you can see, until they appear as fibrous septa between the lobules which are pierced separate and apex upwards. I know it will be very difficult to understand, but once I go to the next picture you will understand. So basal layer remains intact. So this name will come in your MCQ in during NEET PG. So NEET PG exams, this Henderson-Patterson bodies found in which disease? You can say molluscum. Very important MCQ in your NEET PG. Even they will give the diagram, which diagram I will show you. So once you remember this, you will never make this mistake. So cells at the core of the lesion show the greatest distortion and are ultimately destroyed and appear as large hyaline bodies, molluscum bodies, but they will not give molluscum bodies, they will give this Henderson-Patterson, because found in which infection? Molluscum contagiosum, containing cytoplasmic masses of viral materials. Inflammatory changes in the dermis are absent or slight. Lesions of long duration may exhibit chronic granulomatous infiltrate. In spontaneous regression can occur if the immunity increases, so it can heal by itself. So this picture is very common, you will get in your MCQs. They will give you the picture and they will give you MCQs. Which infection? So you can see molluscum bodies, this type of picture, lobulated epidermal growths, and you see basement membrane is intact, complex damage. So this is very common picture you will get in NEET PG. Okay. This picture you can see. So you can see the pink material. So you can see it is a cup-shaped lesions composed of molluscum bodies. Okay. So this picture they will give you. Okay. So clinically you can see in this way. Clinical in OPDs you can see this type of lesions. Incubation period is 14 days to 6 months. Individual lesion is shiny, pearly, white, hemispherical, umbilicated papule, which means show a central pore. So see that is the umbilication. You can see the center one, that is umbilication. So umbilicus, so it's dome shaped and again central depression. So size ranges from 1 mm enlarging to 5 to 10 mm in 6 to 12 weeks. Rarely a lesion may become considerably larger if solitary. Giant molluscums you can see in HIV patients. After trauma or after several months, inflammatory changes results in suppression. You can see secondary infection also with this virus, very common. So what are the areas which they are affected? Mainly axilla, face, arms. So these are tiny bumps you can see in children. So clinical variants, distribution mode depends on mode of infection, type of clothing, climate, temperate regions, mostly the neck or the trunk. In the tropics it is mostly on the knees. In teenagers and young adults, anogenital area most common due to sexual transmission. Healthy subjects, facial lesions, particularly eyelids, scalp, soles may display an atypical form. Immunosuppressed patients, widespread and refractory mollusca in the face seen in HIV disease, oral lesions on the lips, tongue, buccal, mucous membrane, giant or widespread molluscum lesions. These are we find in immunocompromised and HIV patients. Molluscum can also occur in scars and tattoos because injury is there, and also tattoo needles, it can contain the virus. If it is not properly sterilized, then you can get the virus. So follicular molluscum, this is a variety reported. So you can see these are the giant molluscum on the face in AIDS patient. So this picture you will get in this one in NEET PG. Yeah. This is histological, means you do a biopsy, you do a PAT stain, hematox H&E stain, and you can get this picture. So they will get in MCQ, very common. Okay. So what are the differential diagnosis? Well, if somebody practices skin, you should know which are the mimickers, because most of the skin lesions look same, but they are not same. So these are the differential diagnosis. In skin, any short note, always write a differential diagnosis, because that is an important part of what will I say, in dermatology. So like you can also tell molluscum and acne, no? It sometimes you can confuse with acne also. So small solitary, you can see pyogenic granuloma, keratoacanthoma, squamous cell carcinoma. Warts can also look like, I'll come to the next topic, warts and cryptococcosis. These are very like rare diseases. Complications, like in 10% of cases, particularly in atopic patients, patchy eczema, irritable, develop one or more lesions, erythema annulare centrifugum. These are very terminology you don't have to remember. This is just an extra notes. Chronic conjunctivitis, superficial punctate keratosis, so you can around the eyes. Okay. So most cases are self-limiting. If the immunity improves, it can go by 6 to 9 months if left untreated. Some may persist to 3 to 4 years. Inflammatory responses around the lesions indicate immunological resolution. Depressed scars or anatoderma-like lesions can occur. It can form scars. So investigations, basically it is clinical. You can do a microscopy and histopathology. So mostly it is clinical. So management, as I said, so it is contagious. So transmission has to be stopped. Avoidance of shared tiles, avoiding contact sports, abstaining from usual communal baths. So when you go to swimming pools and all, you can also get this kind, you can also get contacted from that. Treatment is very slow, lesions are asymptomatic, sometimes eczema can occur. Choice of treatment also depends on the age of the patient, number of lesions and position of lesions. Aim is to destroy the infected epidermal cells, stimulate an immunological response and directly against the virus. So when I come to the treatment, age also matters and the duration also matters, and also the position also matters. So what are the do's and don'ts? So always wash your hands frequently, wash clothes area in warm and damp water frequently, avoid direct contact, seek treatment, do not scratch, do not share swimsuits or towels, do not share helmets and gloves, and don't participate in direct contact sports. So what are the topical agents we use? Mostly we use cantharidin, trichloroacetic acid, liquefied phenol. Topically, gels we use like salicylic acid, tretinoin, adapalene, nitric oxide, 5 to 10% potassium hydroxide. This is most commonly we use. Benzoyl peroxide cream, tea tree oil. Damage like squeezing out, we do needling and we take it out by forceps. Then immunological we use like mostly imiquimod cream, interlesional systemic interferon, interlesional immunotherapy. Then we do a cryotherapy, liquid nitrogen we use, carbon dioxide laser, photodynamic theory, curettage using curette forceps. Then also use electrocautery machines, we use radio frequency. And these are third line, we use cidofovir, paclitaxel, these are not available easily. So what is the first line? First line we use a caustic destruction like trichloric acetic acid, liquefied phenol, salicylic acid, adapalene, nitric oxide cream, potassium hydroxide, benzoyl peroxide. Surgical irritation, right, electrocautery, second like immunocommod, cimetidine, surgical removal, third line. So mostly in children we use 5 to 10% potassium hydroxide or needling, and young adults we do electrocautery. So this is the first presentation of molluscum. So now we come to the next common viral infection, very common. I think you have mostly seen this viruses very I think in your childhood and all. Wart, like you see on the faces and necks, but sometimes it looks like skin tags, but warts, like in you can get on foot, hands, and in housewives, those who are working with water so much. So wart, very common. So what basically is a common name, what is called infection, but mainly the causative agent is human papillomavirus. So basically this is the microbiology part, not much important, but mainly it is a double-stranded DNA, and diameter is 52 nm. These are not that much important. While writing the shortcut, you can write it is a single double-stranded DNA molecule of 8000 base pairs. So it belongs to two separate families. One is Papillomaviridae and one is Polymyoviridae. So human papillomavirus is divided into two types. One is high risk human papillomavirus, one is low risk. So low risk types cause warts and high risk types can cause cancer. So today I will talk about the low risk type, which doesn't cause cancer. It only causes the warts, so low risk type. So human papillomavirus is limited to basal cells of stratified epithelium. It doesn't go beyond the skin, it stays on the skin. So the virus is cannot bind to the live tissue. I think এটা কি চলছে বন্ধ হয়ে গেছে চলছে So it same thing as molluscum, it infects epithelial tissues through microabrasions or other epithelial trauma that exposes the segments of the basement membrane. So HPV virion associates with receptors such as alpha integrins, laminins and annexin A2. So these are the receptors. So more higher you go, you will learn about what are the receptors. So body has specific receptors which accepts the specific kind of DNA RNA strands. So like why every infection is everywhere, but why not everybody is getting the same infection? So it also depends on the immunity and the receptors. So human papillomavirus may not cause symptoms at once, but they can appear years later. So you may get infected now, but the symptoms appear after many months and years. So it leads to warts, and mostly low HPV type leads to warts, and others high risk cause cancer. So warts, most common symptoms of HPV are warts, especially genital warts. Genital warts may appear as small cluster of bumps, stem-like protrusion. They commonly affect the vulva in women, possibly the cervix and the penis or the scrotum in men. They may appear also around the anus in the groin region. They can range in size and appear and be large, small, flat, cauliflower shaped, and maybe white or flesh tone. So the subtypes, there are many subtypes, but 6 and 11 are common causes of genital warts and laryngeal papillomavirus. So you can get also human HPV infection in the larynx. So you see the picture. So this is what. So mostly we see plantar and flat warts. Common warts raised, rough raised, mostly commonly found in hands and fingers and elbows. Plantar warts are hard, grainy growth on the feet. They mostly appear on the heels or balls of the feet. Flat warts generally affect children, adolescents and young adults. They appear as flat topped, slightly raised, that are darker than normal skin color and mostly found on face, neck, areas that have scratched. So these are the types: cauliflower-like, mushroom type, papillary type, crestate, papular, irregularity. So many types of variations are there, structural variations are there. So you can see there are so many types of warts depending on the site of infection. Anogenital, anal dysplasia, precancerous type, genital cancers, epidermodysplasia, very simple, very rare disease, focal epithelial hyperplasia, mouth papillomas, oropharyngeal cancer, laryngeal papillomatosis. So, I will not talk about the cancer part. So, but human papillomavirus, most high risk type, can cause cancer, mainly the 16 and 18 type. So, these cancers are most commonly involved sexually transmitted infection of HPV to stratified epithelial tissue. So, I think, do you all have taken HPV vaccine? Anybody took HPV vaccine? Took? No one? Yes or no? Gardasil vaccine, nobody took? You took? You took. Yeah, so I think better you take it, all of you. Which age you took? 12 years? You do not know. Then how do you know that you took? Huh? Your parents give you. Right. So those who have not taken, you can take it. This is very important. Because females are very highly risk, because cervical cancers are very common. So that's why it's better to take it. So transmission is skin to skin contact. Having vaginal, anal or oral sex with someone who has the virus, most commonly spread during vaginal or anal sex, commonly that nearly all men and women get it at some point in their lives. So better to take it. Can be passed even when an infected person has no signs or symptoms. Can develop symptoms years after being infected, making it hard to know when you have first become infected. So in most cases, HPV goes away on its own and does not cause any health problems, but when HPV does not go away, it can cause health problems like genital warts and cancer. So traditional methods of viral diagnosis such as electron microscopy, cell culture, immunological methods which are not suitable. So basically it is like clinically we see it, but cervical part you have to do colposcopy, acetic acid test, biopsy, DNA test like PCR, southern blot, in situ hybridization, pap smear. Colonoscopy, PCR methods, these are very costly methods and not available everywhere. Serological assays not available everywhere. So biopsy is one of the most common method we diagnose warts. Pap smear, pap test is a screening test. Apart from pre-malignant and malignant changes, viral infections like HPV infection and herpes can also detected. Acetic acid test, vinegar test. So these gynecologists mostly do it. Pap smear test, very important. Early precancerous changes detected through pap smear. A woman may have cervical cancer, not know it because it may not have symptoms. So pap smear is very common. I think gynae teachers will explain you more. But I think every year women like after 18 years, pap smear is very common, especially after marriage, and also regular checkup with pap smear is very common. It should be done. So the treatment, there is no specific treatment, but however it can be treated with salicylic acid, imiquimod, podophylox or podophyllin, trichloroacetic acid. So these are either the patient applies it or the physician applies it. Surgically, like electrocautery, same like with same as molluscum, freezing with liquid nitrogen, cryotherapy, electrocautery, surgical removal, laser removal. And here are the highlights, like condom use may reduce the risk of genital human papillomavirus infection. So 3 vaccination which I was talking about, 3 vaccinations are available to prevent infection by some HPV types. All protects against the 16 and 18 which mostly cause HPV associated cancers. So I highly recommend to take the vaccines. Like Gardasil, very much available in every district has some vendors. So this is, you can take it. So Gardasil, which has HPV 6 and 11, which causes 90% of genital warts, and quadrivalent vaccine. Then other vaccines are like Cervarix, Gardasil 9. So Gardasil is very common vaccine which is available. Prevention is vaccination. avoid skin to skin contact by not having sex with strangers, use of condoms or dental dams. Through all these things, protection is very important.